What is rehab or rehabilitation? My name is Fred Begaris, a board-certified sports and spine medicine physician in Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab Podcast. Okay, this talk is about post-procedure pain and diagnostic blocks. I'm a huge fan of diagnostic blocks because with spine-related disorders or musculoskeletal-related disorders, it can be very difficult to tell exactly what's causing the pain. Given enough time, you image any structure and you'll start to see degenerative changes. And it's hard to know what's just general changes versus what's actually causing the pain. So I'm a big fan of using diagnostic blocks. And the idea behind it is that you have a hypothetical painful structure, whether it is a facet joint or knee joint or a tendon or ligamentous structure. You place an injection with an anesthetic, which should last for a couple hours, typically lidocaine, and you take a pain level before and after. The numbing agent will act fairly immediately from minutes to hours and should last for a couple hours. And if the pain improves, then you have evidence that suggests that this is likely the painful structure. Now, it sounds like it's fairly simple, but having done this enough time, it's not always that clear because remember, there is another factor in the picture, which is the patient. And being able to tell what is a positive diagnostic response is very, very important. So the underlying theme when it comes to these type of injections is really setting expectations. So you have to set the expectation for the patient on what they will experience from beginning to end in terms of are they going to be noticing any post-procedure pain and also what type of pain relief to expect after the injection. Now, it can be very difficult to tell exactly what the pain is coming from. When you live with chronic pain, it can sometimes just be difficult to tell, is this normal pain, pain from use? And sometimes even after a block, people will report that the painful sensation is gone, but then now there's another sensation underneath. So sometimes there's almost kind of like layers that you have to dig through. And that's where really explaining to your patients, the entire day and what to expect is very, very crucial. Now, in my particular kind of style and practice, I will always prepare my patients by telling them how to measure their pain. And I know that it sounds probably a little bit obvious, but it really isn't. So I usually will have people pick an activity that will produce pain. That could be sitting, standing, walking, putting their pants on. So even right after an injection, let's say a medial branch block of like the lumbar spine, while they are transferring off of the stretcher, while they're getting dressed, I want them to start to notice the pain. And I really try to emphasize that I would love for the pain to be 100% gone, but I expect there to be some discomfort or pain. But the presence of pain doesn't necessarily mean that it is a failure. And what I mean is that I suspect that some patients expect there to be 100% relief. And that's not always the case. Sometimes there's 50% relief, sometimes there's 90% relief. But the fact that there is a remaining, 10 to 50%, sometimes they'll just say, well, it didn't work because it was only 90% better. And that, from a physician standpoint, that's the wrong conclusion. But for the patient, you have to set that expectation so they don't misunderstand or report incorrectly their experience. So I really try to lay out the groundwork for the expectation. Now, telling the difference between post-procedure pain and the pain that brought them in. These are needles, so they can always deliver some amount of symptoms. A lot of patients can actually tell the difference between the pain that they came in with and the needle pain. And that can be very helpful because if your patient is quite savvy, they can really differentiate the two and give you a very clear answer. But again, sometimes it's when things are painful, you introduce a needle, which makes things more painful. It can really muddy the water. So I really have patients identify certain activities, again, sitting, standing, walking, anything that they can do directly after the injection. That way they have some sort of activity to measure in addition to any pain relief. Because in my mind, some people will experience 8 out of 10 pain, and right after the injection, the pain drops down to 1. That's a little bit more obvious. Now, for some people, they will have 8 out of 10 pain, and their pain reduces to, let's say a 4. But in addition to that, they will say, you know what, I was able to stand, I was able to walk, and I was able to do difficult activities for a longer amount of time. And that's fairly significant. And any physician that is recording this information has to take that into account. So the numerical value plus something else. So it has to be a very well understood and recorded event so that the correct conclusion can be drawn. The next thing to tell the patient is how long is the medication supposed to last. Now, when I do my diagnostic injections, I do not put in any steroid. So it's just pure anesthetic, typically lidocaine. So I expect the medication to last for a couple hours, in the order of maybe 2 to 4 hours after the injection. And you have to tell the patient that the pain is likely going to come back. Because if you don't, then they draw the conclusion that, it didn't work because the pain came back. So again, you have to do a lot of education. You almost have to really prepare your patient in order to have a good diagnostic trial. Oddly enough, there is kind of the science behind the pharmacokinetics of how long these medications should last. And anyone that's done this enough has come across patients that have had a diagnostic block, let's say 90% relief immediately after the injection, and it lasted past the 4 hours. And, I personally still count that as a positive block, even though things should wear off. I'm curious to hear how other people actually interpret that. I have, in conferences and in talking with colleagues over the years, some people don't really count that as a positive block. They really expect a beginning and a clear end to when the medication should stop walking. If it's anything but that picture, it's a negative block. And I think there's a lot to be said to that. I personally don't think that is the correct conclusion. On the flip side, I have had some people that respond really late, as opposed to responding within within 10 minutes of the injection. They get immense relief, but it's hours after the injection. And again, I think there might be a little bit of an argument for this being a non-diagnostic injection from my standpoint. But, I don't think we can ignore the variability of humans and the metabolism of some of these medications. Some people might metabolize these medications fast, some people slow. So I think that there has to be some wiggle room. Clinicians cannot be so... Obviously, we do these injections to pick patients for certain procedures, and we want to make sure that we are not collecting too many false positives. But realistically, we're dealing with humans. The answer is coming from their brain, not their muscles or their joints. So you have to actually pay attention to who you're talking to, because that really does matter. And at the end of the day, you can educate your patient as much as you can, and that's all that you can do. But it's sometimes just very difficult to tell. The patient may not be great at reporting, and therefore you cannot be conclusive. Sometimes I feel people will conclude that, oh, this block is negative. They had a non-diagnostic response. Therefore, this is not the structure. I think that's a reasonable conclusion, but what if your patient is not reporting the symptoms correctly, or maybe you are not educating them enough about what to expect, and they give you a false negative answer. So I think that it's kind of food for thought. I know when in my fellowship training, we have certain questions that we ask, and we have them fill out questionnaires and things like that. But again, you're really kind of dealing with humans. And on the flip side, we do have to be careful. And I am very clear with patients and when telling them, the block does not lie. So if it works, I'll believe you. But if you tell me it works when it really didn't, just for the sake of having going on to the next step of the series, in my experience, that the final procedure doesn't usually work. So I do think you have to factor that in, is that I think any patient is susceptible to giving a positive answer. Sometimes there's confusion, sometimes there's desperation, they just want something to work. But over the years, I've really started asking people more in-depth questions on what they're experiencing directly and even during the injection. I think it has made me a much better clinician. It's definitely given me a lot more insight into kind of what we were taught in training. It's very muddy. It's not black and white at all. But anyhow, I hope this was helpful to you guys. Any clinicians, young attendings doing these type of injections, even if there's some patients out there listening, pain is one measure. So I think it is a great idea for you to also listen to this podcast, or this episode, to give you an idea of what physicians are looking for when reporting your symptoms. Anyway, I hope you guys enjoyed this. You guys have a nice day. Thank you for listening to the Talking Rehab Podcast. I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.